a contact. Now, this is my DNS spin on this. We know that there's a reflex zone on the medial inferior angle of the scapula and on the acromion. The reflex zones in DNS to initiate a reflexive response of stabilization on this is to direct the scapula towards the support zone, which in a prone position would be here. So I am just simply directing my pressure in that direction, okay, to stimulate the muscles that would support that upper rotation. In manual, like I don't know what world they're in. They're in the world that is not neurophysiological. They're in the world that requires some kind of a physical impetus or biomechanical change to change the movement response. But we know through reflex locomotion that these 2 points stimulate a reflexive response of stabilization. So if I want to help him in that upward rotation response, I'm going to say, Corey, lift your arm up over your head. And I'm just going to kind of lightly facilitate that pattern for him. Does that make sense? I'm not really pushing him there. I'm just kind of stimulating those zones.
Mm-hmm.
Dude, I see that pause all the time. I manually muscle test people all the time, and they suck. They're really bad. And I see a glenohumeral joint that does not move, but I see a scapula that downwardly rotates. So I say, it looks like the scapula is not supporting, and the glenohumeral joint seems okay. So all I do is place my hand on those same reflex points with not a heavy contact, just a little bit of support, and then I retest that manual maneuver. Now, if he still has weakness or pain, I'm very confident that it's probably localizing in towards the rotator cuff. If he all of a sudden is 5 out of 5 strong, I can push my body weight and he isn't budging, which happens, then I'm very confident that I don't need to worry about the glenohumeral joint first. I'm going to tackle the scapulothoracic articulation as my primary first intervention. Does that make sense? So you can tweak the scapula in any way you want, right? You could even put it in a more anterior tilt. You could put it in more protraction. You could put it in retraction. You can change the position of this in many different directions to figure out which position relieves their pain. And that's during motion or manual muscle testing. And it does not matter which motion it is. It could be any movement that is painful. You are trying to modify their symptoms, which will help you inform your treatment and rehab decisions, especially in early care. With me? Okay, so you got scapular modification, thoracic modification, you've got glenohumeral glides. Now, glenohumeral glides in this world is more, again, proprioceptive neuromuscular facilitation in the sense that I am just giving him a feedback cue. So Corey, go ahead and raise your arm. Back down. Jeremy Lewis has like a mobilization belt that he uses for this. It works well. I've always just used my hands. It seems to work well too. Only problem is they can't take my hands home with them. So do it again. So this is more depression. Go again. This is more posterior glide. Go again. That's more anterior glide. Go again. That's external rotation. You know what I mean?
So you just go through all those to see what tension builds up, or
pain-free.
Just pain-free.
Symptom modification.
Okay.
Yeah. So if they had restricted range of motion and because it was painful, or if they had a manual muscle test, if they're here, hold, and it was weak and painful, I might do that and then repeat the test. Okay? So I was staying at lunch, I had a guy who had a banker repair like years and years and years ago, and he had a humeral head that was significantly gliding anterior superior in basically abduction and external rotation. Okay? So he also had a lot of like atrophy in his infraspinous fossa. He had no complaint, by the way. There was no pain. The only reason why I went there is because he's a long-term patient. He comes for optimization care. We had dealt with everything else, and this is where I landed on this day because it was not moving well. And he said, it's not a problem, it just is like that because of the surgery. And I kind of believed him for a long time. And then we played around with this symptom modification stuff in humeral glides and found out that he actually had full external rotation when I modified the position of the humeral head. So his line your back, what I did with him, so you know, like if that didn't work, then take them here. Okay, well, there, okay, ow. Okay, Corey, that hurts. Just come here. I'm just going to take your humeral head here and just relax there. And I'm just going to take you there. Does that hurt, Corey?